But Richard, what you mentioned is very critical, and I go back to Jeff on the issue of response, which is very challenging and something that we deal with as oncologists. Tell us more.
Yes, we have entered the world of acronyms that are very difficult to figure out. The bottom line is the following. We know, and it started with the fact that after local regional therapy, as you well know, the tumors do not shrink. So the only accepted method to assess response in oncology is RECIST, which is the unidimensional size measurement of the tumor. Because it wasn't shrinking, we had to come up with surrogate markers of tumor response because patients want to know whether their tumors are responding to the treatment. And it became obvious that the only way to do this was to look at the contrast enhancement. And that is what led to the European Association for the Study of Liver Criteria, known as EASL, where it was a bidimensional measurement of the residual enhancing portion of the tumor after either contrast enhanced CT or MRI. And then, because that was more complicated, the MRECIST concept was created, where instead of measuring bidimensionally, you're actually measuring now unidimensionally the longest axis of the residual enhancing portion of the tumor. All those, EASL and MRECIST, are based on the notion that lack of contrast enhancement equates tumor necrosis. And it is now applicable to these anti-angiogenic therapies, sorafenib, but although beyond liver cancer, because we know these drugs are not necessarily cytotoxic, they do not kill necessarily the tumor cells, they prevent their regrowth or whatever else, and as a result, we had to apply these non-traditional methods to assess response, and that is what we deal with. So to assess sorafenib failure is very difficult, like it is to assess failure to respond to chemoembolization because they are somewhat unreliable. It's very, very difficult. When you have a well-delineated tumor, yes, it's easy, but when you have these more infiltrative tumors or when you have multifocal tumors, which one do you pick? How do you assess? It can be very, very complex.
Unfortunately, on that question, we are leaving you a little bit with a little bit of unclear, settling answer, which is no doubt we recognize that those kind of tumors will embed within the parenchyma. Sometimes it's hard to delineate beginning and end of a tumor, sometimes with the necrosis component. And we're not necessarily sure that any of those novel approaches in radiology, like modified RECIST, has been validated prospectively enough that we can say this is the applicable part. Nonetheless, it keeps the door open in regard to make sure that with your radiologist, know what they're talking about in regard to what kind of therapy you're applying. I think this kind of discussion is very important. Please look at the CAT scans yourself because you might be surprised that sometimes some of those components are noticeable to you. And hopefully, you know, the good work that many of our colleagues are doing will kind of lead to some answers in that regard. I'm going to leave this last part, which is something that's really a very hot item that we're hearing about a lot nowadays, which is the issue of immunotherapy in regard to cancer. I'm not sure really how far we are in regard to HCC immunotherapy. If anything, I'd like to mention some of the work that has been already reported, and especially on anti-CTLA-4, where a phase 2 trial of 17 patients with hepatitis C patients with HCC received the therapy, and there was some kind of improvement in what we call time to progression of about 6.5 months. This is really how much data we have. Nonetheless, there is quite a bit of rationale on the applicability of PD-L1 and anti-CTLA-4, as well as other potential combination of or variation of in regard to immunotherapy, that I'm sure it's a field that's kind of like ready to go, not only in HCC, but many other treatments, many other cancers. However, one of the questions that come along that discussion, we're talking about immune modulation. And remember, we spoke in the beginning about hepatitis C and hepatitis B, and we have, in other words, a possible active viral infection. So let's hear from Bob about how do we settle that question.
One of the big reasons we have a fear in this space, of course, is the reactivation that we've seen with immunosuppressive immunomodulators like rituximab. And of course, there's breast cancer drugs and a variety of other ones that have reactivated hepatitis B. Now we're switching to de-repressing the immune system, the PD-1, PD-L1, et cetera, that these can now remove control over something that may be immune exhaustion and allow the immune system to come back and attack hepatitis B or C. So you might attack the virus and the liver cancer at the same time. The companies are looking very closely at this. I think these drugs may be actually developed for antiviral effects as well. So I'm very excited about this space.
That's great. And actually, I'll take that opportunity also to ask Jeff, that novelty might be actually applicable also when we come to the local therapies. What's happening in that arena as far as advancement?
I would say two major breakthroughs. One is the ability to deliver very small microspheres as opposed to the first generation of microspheres that were in 100 to 500 micron range. Now we can actually deliver beads that are 40 microns in size, loaded with chemotherapy, and more importantly, imageable. So you can actually track them and you can verify where they go. And this imageability allows you to also do dosimetry because you can calculate the amount of chemotherapy that is actually delivered to the tumor. So that's one breakthrough. The other one is what you just pointed out, the immunomodulation with cryoablation, where by combining it with anti-PD-1 inhibitors, you can actually by removing the brake to the immune system, you can actually stimulate even more vigorously an immune response to the tumor by cryoablating any tumor site. So it doesn't have to be the liver tumor. It can be a patient with, for example, multiple sites of disease, even in the lung, extrahepatic disease. By just putting the probe on one of the tumors, you can actually stimulate the immune system that is going to be exacerbated or increased by this anti-PD-1 inhibition.
Thank you. This was really a tour de force and a great discussion. We have reviewed and discussed a lot of information on the multidisciplinary treatment of hepatocellular carcinoma. To close and to give an opportunity to keep that spirit of the panel discussion, I'd like final words from Richard.
So clearly this is a complicated disease. Patients are, I think, best served initially getting a consult at a large tertiary multidisciplinary program. Sorafenib remains the standard of care, but we can do better, and that makes it imperative to get patients into clinical trials.
Jeff?
I would completely agree with that. It's truly multidisciplinary, and you have to be passionate and engaged into the disease because really what we're all here for is patient care.
Bob?
I think screening, surveillance, detecting liver disease, detecting liver cancer early can really change this entire landscape. So providers and the oncologists can carry this message back to the primary care community. They can be our partners in delivering this message.
Adam?
100% agree. I think in the next 20 years, you're going to see incredible new technologies and new drugs that are going to make a definite impact in this disease.
And if I may add, please make sure that you keep engaging with the research community. Clinical trials are going to be very critical in that disease so we can move to a better and improved outcome for our patients. On behalf of the panel, we thank you for joining us. Thank you.